Thank you very much, Fernando, and thank you to the rest of the organizing committee, and to all of you who are still here on the last day of the meeting. We're going to talk about the axilla, and we're going to start with Halsted, because his premise was that if you could do a thorough enough local control, you would actually be able to cure breast cancer, which at the time was considered incurable. As you all know, his operation entailed removing the breast, a large amount of skin, all of the muscles, and a very thorough dissection of the axilla. Here, what he's showing you on the bottom bar of the graph is his rate of local recurrence compared to all the major clinics of Europe. And coincident with this improved local control, he reported that about 30% of patients were cured at 5 years, which at that time was pretty good. And this was the reigning model for the treatment of breast cancer, probably for the next 70, 80 years, until Bernard Fisher, who you all know, who really popularized the idea that lymph nodes are not simple filters, that breast cancer is a systemic disease from the outset, and that variations in local regional treatment are unlikely to affect survival. It's really the systemic aspect that deserves emphasis. And finally, Sam Hellman proposed an intermediate model, oligometastases, suggesting that breast cancer is a wide spectrum, and I think this is what we all certainly believe now, that even with regional node disease, there is the potential to cure. And as we're seeing now, even with systemic disease, there may be a potential to cure. It took a long time to really prove that local control and survival are related, but the Oxford Overview in 2005, which I still regard as one of the most important papers of my professional lifetime, finally, in meta-analysis, showed us that by reducing local recurrence, you have a modest improvement in survival, but only when you reduce local recurrence by more than 10%. Smaller reductions in local recurrence did not translate into survival. So in strategizing for axillary management, we think a lot about what the expected rates of local recurrence would be. We all know that sentinel lymph node biopsy works, and the intent, of course, was to reduce the morbidity of axillary dissection, but not lose that prognostic information from the nodes. And these are observational studies in which the authors did sentinel node with a backup axillary dissection. There was a false negative rate, but the procedure worked well. 5 randomized trials have looked at it the same way, and you see false negative rate between 5 and 10%, and about 2/3 of patients having disease only in the sentinel node. But those false negatives do not turn into axillary local recurrences. And here you see across 48 series a very low rate of early axillary recurrence. You see in the Milan randomized trial, the first of sentinel node, very low recurrence. And in B32, in which the false negative rate was 10%, less than 1% axillary recurrence at 8 years. False negatives do not turn into axillary local recurrence. Axillary local recurrence is an early event. This is a very nice meta-analysis showing you that across the sentinel node literature, most axillary recurrences were in the first 2 years. This had a 34-month median follow-up, but we've followed our sentinel node negative patients out to 15 years and have about a 1% rate of axillary recurrence, again with most events occurring in the first 5 years. And the B32 trial, which compared sentinel node alone with sentinel node plus axillary dissection, really asking whether false negatives affect survival, found no difference in 8-year survival between sentinel node and axillary dissection, or in disease-free survival. One of the things that really excited us about sentinel node biopsy was that we could stage the nodes so much more thoroughly. And with immunohistochemistry, we were seeing single cell metastases, whereas with H&E it required much more disease. And we thought this was a very significant advance, improving our staging accuracy. And we even went back and looked at a group of patients from the 1970s, all of whom had an MRM with an axillary dissection. They were all node negative. We took their nodes and sectioned them according to our sentinel node protocol with serial sections and IHC. And what you see here, I can go back, is that it appears that the missed disease that you find in the nodes is prognostically significant, converting them to node positive by IHC, intermediate between that of negative and H&E. So we felt that this was a significant amount of disease we were missing, and it should be very important to do these extra studies on the nodes. But in fact, that was 40 years ago before systemic therapy. And here's what we have today. The Z10 trial, patients having sentinel node were treated only on the basis of IHC analysis of their nodes, H&E analysis. The IHC was done in a blinded fashion, and with or without the knowledge of IHC, what you can see is that the 5-year survival is exactly the same. So it did not appear here that that was important. In B32, a much larger study, they went back and resectioned the nodes with IHC. They found that the patients who converted to IHC positive did do a little bit worse. This was statistically significant, but virtually all of these patients had already received systemic therapy. So again, it's not really clear that IHC helps. And based on these results, we actually went back to just doing H&E on our sentinel nodes, except for problematic cases for the pathologist. Do we always have to take out the nodes if the sentinel is positive? Well, even before we had the Z11 trial, and these are data across the United States showing what surgeons were doing with their node-positive patients. And what you see here is even with macrometastases, 23% were not going on to axillary dissection. With micromets, 36% were not going on to axillary dissection. This did not seem to have any effect on survival, whether or not you did an axillary dissection, and whether you had micro or macro metastases. Now, this is all retrospective data. It's not quite the same as a randomized trial, but it's reassuring. We have many studies that look at patients who had sentinel node micromets and did not have an axillary dissection. Local recurrence, very, very low. And more importantly, we have a randomized trial which asked exactly the same question. Patients with sentinel micromets were randomized to axillary dissection versus not. 13% of the axillary dissection patients had additional positive nodes. The median follow-up here was 5 years, and there was no difference in the rate of local, regional, or distant recurrence. We have a lot of studies asking whether you have to take out the nodes in macromets, and here these patients all had no axillary dissection. The local recurrence rate was under 1%, with a follow-up of about 3.5 years. And most importantly, we have a randomized trial which asked exactly the same question, Z11. This was a trial in which if you had positive sentinel nodes, 1 to 2 positive, and were having breast conservation with whole breast radiation, you would be randomized to axillary dissection versus observation. This trial had intended to accrue about 1,800 patients, but was stopped just shy of 900 because of slow accrual, and also because of an extremely low event rate. They realized that based on their low event rate, the trial would have to become impossibly large to have statistical power. These were patients who were having breast conservation, were clinically node negative, and patients with bad disease, matted nodes, or 3 or more, were excluded. The intent was that the patients get only breast radiation and not nodal radiation. The axillary dissection arm had exactly the same rate of systemic therapy, chemo or hormonal, as the sentinel node only arm. So clearly the axillary dissection did not alter the systemic treatment. Local, regional, and distant recurrence was not different between the two groups. Even though 27% of the axillary node dissection patients had residual disease in the axilla, in the sentinel node only arm, axillary local recurrence was 0.9%. Nodes left behind not turning into local recurrence, presumably because of the effect of the systemic therapy and the radiation. No difference in the overall or disease-free survival between these two arms. And with a recent 10-year update of Z11, there still is no difference, and there has only been one additional patient recurring in the axilla for an axillary recurrence rate in the sentinel node arm of just over 1%. One of the critiques of Z11 is that about 20% of patients did receive lymph node radiation, and this was a violation of the protocol, and it certainly suggests that some of the low local recurrence rate we're seeing is due to the effect of the radiation, not just systemic therapy. This was just an audit of a subset of the Z11 patients. We have recently looked at our own Z11 patients, and about 20% of them also got nodal radiation. And our conclusion from that was that with the Z11 protocol, you might need to give nodal radiation, but a majority of your patients, 80%, do not need it. And here's our current algorithm. We adopted this in 2011 when the Z11 trial came out. And among our patients who meet the Z11 criteria, clinically node negative, 84% of them were able to avoid an axillary dissection. This has been hugely practice changing for us. What it means is we no longer do intraoperative frozen section on our Z11 patients. Very few have to come back to the OR because of a greater than expected extent of nodal disease. We need to mention the Amorose trial. In patients in whom the sentinel node was positive, they randomized between axillary dissection and axillary radiation. This was a beautifully done study from the EORTC. What this showed is the rate of axillary local recurrence was close to 0 in both arms. A little over 1% for the sentinel node radiation arm. And this was the same local recurrence rate they observed in their patients who were sentinel lymph node negative. The disease-free and overall survival were no different between the two arms of the trial. And most importantly, the morbidity of axillary radiation was about half that of axillary dissection. And this is something that as surgeons, I think we have to come to terms with and accept. This is the first really good head-to-head comparison we've had between axillary surgery and axillary radiation. And to me, it clearly shows that the morbidity of axillary radiation is less. So in your sentinel node positive patient that you're agonizing whether to go back and do the axilla or not, consider radiation. The morbidity may be less. Now, can we extend a policy of sentinel node positive no axillary dissection beyond the Z11 selection criteria? And this has been the subject of lots of debate in the US, and we actually have some interesting data to address all of these questions. What about the patient who has abnormal axillary imaging? They may be clinically node negative, but the ultrasound or other imaging is abnormal. My colleague Melissa Paluski did a very nice study in which she took Z11 eligible patients These were patients who had 1 to 2 positive sentinel nodes undergoing breast conservation and whole breast radiation. And she asked, if the imaging is abnormal, are we really justified in doing an axe dissection? So in this population, they all had had a mammogram. A little over half had had an ultrasound, and 40% had had an MRI. If your mammo was abnormal, 68% of those patients could still avoid axillary dissection. If the ultrasound was abnormal, 70% of them could still avoid an axillary dissection. And if the MRI was abnormal, 73% of them could still avoid an axillary dissection following the Z11 protocol. So axillary imaging, regardless of your modality, is not all it's cracked up to be. She then asked, what about the patient who has abnormal axillary imaging and has had an FNA of the node, which is also positive? Again, clinically node negative, but a positive FNA of the axilla. Should they go straight to axillary dissection? Well, in this population, 47% of the patients only had 1 to 2 positive nodes, remaining Z11 patients, and could avoid an axillary dissection. So even with a positive FNA, half your patients do not have to go back. Here she asked whether if you see more than one abnormal node on imaging, do you have to do the axe dissection? And even here, 1/3 of patients could avoid axillary dissection. And so she concluded that for clinically node-negative breast cancer with abnormal imaging, half of them do not need an axe dissection. And even if the FNA is positive, half can avoid an axillary dissection. What about mastectomy? We often don't routinely give radiation after mastectomy. So if the sentinel node is positive, do we have to do an axillary dissection in that setting? We have a growing number of patients, both with mastectomy and with breast conservation, who were sentinel node positive, who had no axillary specific treatment. This was a carefully selected group of patients. As you can see, they had small tumors. About half of them were positive only on immunohistochemistry, so low volume disease. Very low predicted rates of residual disease in the axilla, but they got no axillary specific treatment. And you can see at 5 years median follow-up, no difference between these groups in the rates of local or regional node failure for either breast conservation or for mastectomy. So there does seem to be a group of mastectomy patients, sentinel node positive, not getting radiation, in whom you can avoid axillary dissection. And the UK is actually asking this question with the POSNOC trial. This is basically a redo of Z11, but it also includes patients having mastectomy, not just breast conservation. And this should give us a more definitive answer as to whether the mastectomy patients can also follow the Z11 protocol. What about neoadjuvant? This has really changed things for lots of us. We all know from the 9 neoadjuvant trials that there's no survival difference whether you give chemo first or surgery first. This is familiar to all of you. We know from the Cortazar meta-analysis that responders always do better than non-responders. These are the patients with a PCR, showing you better survival with a PCR. We know that biologic subtype is related to tumor response. So particularly for responsive subtypes, the PCR is quite high as 50% or more for the ER-negative HER2 positives. I think we'll be hearing more about this. It's not yet clear that strategies which increase the rate of PCR improve the survival rate, and this is what the meta-analysis concluded. we are using PCR as a surrogate for survival benefit and increases in PCR as a surrogate, but it's not altogether clear that increasing PCR rate does improve survival, at least from these studies. We know that neoadjuvant allows you to do breast conservation more often. In the B18 trial, it was largely for the patients with T3 cancers, and overall about 7% more patients were able to have breast conservation with chemo first. We know that chemo downstages the axilla, and in B18, about 1/3 of node-positive patients became node-negative. We know that as chemotherapy has improved, the rate of conversion from node-negative to node-positive, or node-positive to node-negative, goes up as you improve your chemotherapy regimens. And here's our most recent contemporary data on a group of neoadjuvant patients, all part of our prospective neoadjuvant database, in which we looked for the node-positive patients at what the nodal PCR rate was by tumor subtype. And what you see here for the ER-positive, HER2-negative, it's 21%. This is higher than the PCR rate in the breast. It's about double what you'd see in the breast for these tumors. But for ER-negative, HER2-positive, the PCR rate was 97%. And this immediately raises the question whether, for patients with responsive subtypes, we need to be as aggressive surgically as we've been up to the present. If you look across the sentinel node literature for patients having neoadjuvant and have sentinel node biopsy after neoadjuvant, it appears that sentinel node works in this setting as well. You don't find it quite as often as you do with upfront surgery, but the false negative rate is about 10%. This was across 27 studies. And if you look specifically at the studies where the patients were node positive up front and then had sentinel node with a backup axillary dissection, you see that the false negative rate is a little bit higher than it was in the overall group of patients, and the success rate again was about the same. And in this series, in this group of series, about 1/3 of patients had a PCR in the axillary nodes. We have 3 prospective trials which have looked specifically at sentinel node after neoadjuvant in node-positive patients. And these show strikingly similar results. What they show, first of all, is that you should remove more than one sentinel node to minimize the false negative rate. It drops under 10% when you've removed 3 or more. So when we're doing sentinel node post-neoadjuvant in a node-positive patient, we're always trying to get at least 3 sentinel nodes. If we only get 1, we still tend to default to an axe dissection. So this is a setting in which the technique of sentinel node biopsy is particularly important, and we try very hard to get 3 nodes. It's important to use dual agent mapping. With both isotope and dye, the false negative rate is about half that of single agent mapping. So sentinel node in this particular setting, technique really matters. We've become a little blasé about sentinel node in the upfront surgery setting because it performs so well. But in the post-neoadjuvant setting, we really have to try harder. These 3 trials also show something else, and that is that the ability of axillary ultrasound to determine node status after neoadjuvant is extremely limited. And what you see here is the false negative rate of axillary ultrasound after chemo is about 50% in all 3 studies, and the false positive rate is 20 to 30%. So one cannot proceed to an axillary dissection post-chemo based on the results of an abnormal ultrasound. You need histologic confirmation. We have 2 new neoadjuvant trials which are really asking the next question, And these are the trials I think we all should be the most interested in now. These are sentinel node positive patients who have neoadjuvant. In Alliance 11202, if the sentinel node is positive after neoadjuvant, they're randomized to axillary dissection versus no axillary dissection. Both arms will get nodal radiation. And this is really asking, even if the sentinel nodes are positive post-neoadjuvant, a more resistant disease setting, can we still do without axillary dissection if we have radiation as a backup? The B51 trial, if the sentinel nodes are negative, is asking whether we need to give nodal radiation or no nodal radiation. We've always chosen radiation based on the stage of the disease up front prior to chemo. This is really asking, if we get a PCR in the nodes, do we even need the radiation? And these are really trials to watch. They are accruing. We won't have results on these for a while, but this is where we're heading, is a more sophisticated integration of the surgery, the radiation, and the systemic therapy. Finally, the next place we're heading is no axillary staging at all. And these are unpublished results, which I'm showing you courtesy of Viviana Galimberti, who is the PI of this study. This is the SOUND trial. Patients with early stage clinically node-negative breast cancer and a negative axillary ultrasound are randomized to sentinel node versus observation. They now have 2-year results on this trial, and they've seen no difference in any of the outcomes between the observation and the sentinel node arm. In this trial, if your sentinel node was negative, you had no axillary dissection. If it was positive, you had an axillary dissection. And among the group that had axillary dissection, hardly any had extensive disease in the nodes. Most of them either had micromets or only a single node positive, so very low tumor burden. So really our next step with the axilla, at least in patients with early stage favorable disease, will be no surgery at all. Finally, I want to talk a little bit about how we strategize. We can avoid axillary dissection by following the Z11 protocol, or for patients with more disease, we can avoid it by giving them chemotherapy up front. But how do we decide which to do first? And again, my colleague Melissa Paluski has done this very nice study, which literally just came out a few months ago, in which we break out the patients by tumor subtype. These are all patients who were node positive up front. And what we show is that if you have an unresponsive subtype, ER positive, HER2 negative, you minimize the rate of axillary dissection by doing surgery up front and making them a Z11 patient. You still have to do ax dissection in some, but most can avoid it. You're twice as likely to need an axillary dissection if you give them neoadjuvant up front because they have unresponsive disease. So upfront surgery makes sense for the unresponsive subtypes. On the other hand, for the patients who need a mastectomy, where you don't have the backup of radiation, patients with responsive subtypes, HER2 positive or triple negative, minimize their rate of axillary dissection by having neoadjuvant, not upfront surgery. So we are increasingly strategizing what comes first on the basis of tumor subtype and whether the patients are Z11 candidates or whether they will be needing a mastectomy. My conclusions: 70% of Z11 eligible patients with abnormal axillary imaging can still avoid ax dissection. 50% of the same patients, even with a positive FNA, can avoid axillary dissection. And routine triage of clinically node-negative patients to ax dissection on the basis of a positive FNA is no longer indicated. Sentinel node is very well established, and in sentinel node positive patients, axillary radiation is equivalent to axillary dissection, but with fewer side effects and better quality of life. Our next generation trials in clinically node negative are going to compare sentinel node with no axillary staging. Our next generation trials in clinically node positive patients are going to compare combinations of axillary dissection and radiation following neoadjuvant chemo. Two strategies reduce the rate of axillary dissection, Z11 or neoadjuvant. And for unresponsive subtypes who were Z11 eligible, the Z11 strategy minimizes the rate of ax dissection. For responsive subtypes, neoadjuvant chemo minimizes the rate of ax dissection. And finally, regardless of sentinel node status, the role of axillary dissection for the prevention of axillary recurrence is in decline. It does remain an option for the treatment of gross axillary disease and for the salvage of axillary recurrence. This becomes a problem because as we do fewer axillary dissections, we are doing more difficult ones, and this is a challenge for all of us who work in training programs. Thank you very much.